We are live. Hello, Dr. Louise Oliver. It's been ages since I've spoken to you. While I faff around trying to get the Instagram to go live as well, would you mind briefly introducing yourself?
Thank you, Fiona. It's a pleasure to talk to you again. So I'm Louise Oliver. I'm a NHS GP for over 20 years with an interest in women's health. But in more recent years, I'm a functional breathing practitioner because I've become absolutely fascinated that we don't all breathe as nature intended, and how we breathe when we're asleep is utterly crucial. So I like teaching people to return back to breathe as nature intended.
Absolutely. And people are starting to acknowledge how important this is. We've got the new BMS guidelines out that have actually mentioned disordered breathing while we sleep for the first time as an amazing piece of acknowledgement by the very wonderful Zoe Scheidel. And we've spoken about this before because ages ago I did an article for Health Ed Australia where it was actually about dangerous driving and women and sleep apnea. And the expert there from Sleep Clinics was basically saying it is massively underdiagnosed in menopausal women. He reckoned around about 60% or so were just not diagnosed at all. So why is it that we still don't think about disordered breathing in women? Why do we always think it's the fat white truck driver and not menopausal women?
Women breathe differently than men. So when first obstructive sleep apnea, so that's that condition that when we're asleep, so we're breathing through a tube in our neck, it's collapsible at this point, and you're lucky if it's that big. When we're asleep, sometimes it narrows, completely blocks, or it narrows enough that the body feels a threat to life. So the body essentially has to sort of generate a fight-flight response and muscle contraction to open the airway. And when that was originally diagnosed, shortly afterwards, they actually released two papers. One of the founders of sleep medicine, 2002, Professor Guilleminault and his colleagues, and basically said the current measure that we use doesn't work in postmenopausal women with sleep problems. So we've got a huge issue that the diagnostic tool that we use to diagnose it doesn't seem to work in women, particularly around menopause.
That's really distressing.
Yeah. And what's happened? What's happened since 2002? They put their hands up as sleep medicine colleagues and say, we've designed this, it doesn't work. And nothing. What's happened? I do think there's been some work. There is some work going on because first of all, women breathe differently than men. So women don't necessarily complain of snoring and stop breathing during sleep. They complain of the consequences of not sleeping. So, feeling tired, nightmares, waking up unrefreshed, waking headaches, getting up to pass urine at night, fatigue, all these different things. They complain, feeling low mood. So they complain of the symptoms of not sleeping well. They don't necessarily complain of snoring and stopping breathing during sleep. So it's brilliant. This is in this new tool. It's absolutely fantastic. And I hope then if we recognise the extent of the problem, then we need to actually push to say, right, we need new diagnostic criteria, new treatment, because we breathe differently than men. You can't assume that the current treatments will work for us, and we need to push forward with this.
Yeah, the interesting, you mentioned quite a number of things there. So a lot of people say, well, if I'm getting up to go to the loo at night, it's because my bladder is an issue. If I'm waking up at 3 a.m. and unable to get back to sleep again, it's because of anxiety or stress, or it's just because I don't have, I'm not on HRT, or my HRT isn't working for me well enough. So how do we know when it's related to our breathing as opposed to those other things? I know that's a really hard one to unpick, isn't it?
I mean, I think it's really difficult, and I wear two hats. I wear my GP hat in my NHS work. In my private work, I wear my breathing practitioner hat. And the first thing is I ask, do you sleep with your mouth open? Do you have noisy breathing or snoring? Do you stop breathing during sleep? And if you're getting a positive answer with any of those three, you've got a problem with sleep disordered breathing, which is a spectrum. And I think the spectrum Well, one study said that mouth breathing is part of that spectrum. So there's a spectrum of not breathing as nature intended. You know, we're designed to sleep with lips sealed and breathe quietly. You know, our ancestors, if we were noisy when we were in, you know, tribes, first of all, the tribe wouldn't want you to be in their tribe, and you would be at risk of death because you would be noisy to potential, you know, being attacked by animals, etc. So,
I thought you were going to say other tribe members there, and I was going to think that's a pretty
tribe members
up a story.
But you know, we're designed to breathe quietly in and out of the nose. That's how we've been designed. So spectrum, sleeping with the mouth open, obviously noisy breathing, and then obstructive sleep apnea is the real extreme end where we're literally stopping breathing during sleep. So, you know, and I don't think for a moment you develop obstructive sleep apnea overnight. I think it develops over a long period of time. So then there's a whole conversation about, can we not prevent it way earlier? So that's a different conversation. So the first question is really think about how you breathe when you're asleep, and you don't always know. So, you know, when you wake up, is your mouth dry? Is your nose congested? Have you got loads of saliva on your pillow? Your mouth's open if you're doing that. You know, you can record. There are various different apps, some you have to pay for. You can record yourself when you're asleep. You know, the data you get from watches is not perfect, but if your watch is telling you you're dropping your oxygen at night, and there's some of them sort of indicate whether there might be some sort of problem, it's not a diagnostic tool, but if it's telling you you're dropping your oxygen, that's a problem. But I have plenty of people who say they don't snore and they don't stop breathing during sleep. And last week at the surgery, I referred a patient, I got the result back. She said her breathing was fine when she was asleep. She stops breathing 50 times an hour.
What? 50, an hour?
An hour. An hour.
And she had no idea.
No idea. I referred her because she had a number of positive symptoms, and I know the risk factors. And I'm getting pretty good at guessing. I was probably guessing she was going to be between 5, probably like 5 to 8, but 50 times out. And I have to say, that result last week has knocked me sideways, because I thought I was quite good at picking it up. And then you think, well, how many women here, you know, this is absolutely ridiculously common. I've done 66 sleep referrals from February to July, and most of them a lot of them are in people that don't think they snore or stop breathing, and I've got a really high pickup rate still.
Wow. See, I mean, I would never say that I don't snore, and my husband will tell me that I do snore, even though I shall deny it in public. But no, apparently I do snore, and especially if I've been drinking, I will snore an awful lot more. Well, what's wrong with that in the end? Okay, is this damaging my long-term health? Is there a risk attached to this?
There is. And obviously it's a spectrum. Of course it's a spectrum. But I think we really we have to consider that we've got a system in the background called the autonomic nervous system that controls all our automatic processes. And when we're breathing quietly, gently in and out of the mouth, it's stimulating that relaxation repair process, which clearly we need that to be turned on when we're asleep. But if we're even just mouth breathing, if we're mouth breathing, we're being noisy, we're stopping breathing during sleep, it's a spectrum. It'll be worse if you're actually stopping breathing. But your body's fight flight response, your sympathetic drive is turned up. So your autonomic nervous system is more pushed towards survival, sort of threat, opportunity, challenge sort of mode, rather than repair. It's being distracted by maintaining breathing rather than repair. And it is a problem, you know, it is scary, and I don't want to scare anyone if they've got obstructive sleep apnea, but obstructive sleep apnea, it is associated with heart attack, stroke, high blood pressure, heart failure, atrial fibrillation, obesity, diabetes, anxiety, depression, and death, because people fall asleep at the wheel because they're tired.
Yes, that's the other thing, isn't it? I mean, that was the main reason why I was doing that article, was because about, the risk of danger to driving, because people don't really realise when you're that tired or whatever that you're not concentrating on the road. And if you're operating machinery like a car, you will be a danger to others around you and yourself potentially. You will be very happy to hear that, well, I just give myself a shameless plug here, in my book, opening it over here, we have a whole section on sleep and disordered breathing for exactly that reason, because it's the other thing about that is that in doing all of this research as well, in interviewing people like Pauline Mackey from the States, who is a psychiatrist and gynecologist and psychologist, PhD, and one of the leading researchers on brains and dementia, she's basically come to the conclusion that, yes, she was the one who actually discovered the estrogen receptors in the brain about 20 years ago. And she went down the whole road of saying, yes, it must be estrogen that is the cause of all of these things, and then had to actually backtrack and think she'd actually got it wrong. But now she's come to the point where it's the vulnerable brain. So if you've got that combination of untreated vasomotor symptoms, untreated high blood pressure or poorly treated high blood pressure, and sleep apnea or sleep disordered breathing, then you're creating all of these little hyperintensities in your brain, and your risk of dementia is much greater because of those. So that's her sort of line of thought. Of course, more research is needed on all of these sorts of areas, which then means that basically this is really something that we have to take seriously for our future health.
Absolutely. And if we ignore it, this increases the risk of cardiovascular disease and dementia. And we can, obviously, it's a jigsaw puzzle. And Fiona, I see health and well-being as a jigsaw puzzle. How we breathe is one piece. So of course, we want to look at, connection with others, doing challenging things to help our brain, eating the right things, avoiding smoking and lots of alcohol, etc., etc. But you're never, it's one that goes under the radar. If someone's smoking or drinking or not eating the right things, they probably know that. But this is, and they might make a choice that they want to address that or they don't. That's their choice. But with this, people don't even know it's a problem, so they can't even make a choice on it.
Yeah, or if they do, they probably think it's benign and it's annoying their partner, and they can just go and sleep in another room. Yeah. I guess this is the other thing too. I mean, you would think, does the snoring have to be like the I will give you a bit of theatre, why not? I'll take my glasses off in case they fall off my head. Are we really talking about the or is just any kind of snoring an issue? At what line do we go? Oh, it's just a little bit of snoring.
Yeah, I mean, it's so difficult, and I think in women, because what I see in men is men, you ask them and they will say, yeah, oh yeah, I snore, yes, I stop breathing. You refer them and they've got obstructive sleep apnea. What I am seeing now is, obviously, if someone's saying they've got heavy snoring, and particularly, if you can hear it on a different floor, if you can hear it from another room, it's rattling doors, that's loud, that's a problem. I personally wouldn't say any snoring's benign, personally. And the reason why I say that is because I've got clients that monitor heart rate variability, which is like a marker of our autonomic nervous system, which is the system that monitors our unconscious processes in the background. And even the difference in heart rate variability from sleeping with your mouth open and your mouth closed, you get much better heart rate variability by getting your mouth shut. And high heart rate variability is associated with health and well-being. And you take someone who's snoring, mouth breathing, but probably doesn't have sleep apnea, they get improvements in heart rate variability, which means it's improving it's likely to improve their health and well-being. So it's about a spectrum, isn't it? I don't know, if you lightly snore, does that mean it's so difficult, because what I am seeing is I'm getting people who, like this lady, she was denying, I don't snore, I don't stop breathing, my partner says it's fine, and she stops breathing 50 times an hour. So
clearly she wasn't doing the snoring like that, or he would have noticed. It must have just been something far more benign.
And I think one of the things, and this is not in the data, But I do. You know, Jo Inglebush, so she's the dentist that fits devices that help sleep apnea, so mandibular advancement devices. And the women that have hypermobility. Now, obviously, if you're hypermobile, your soft tissues are more flexible. And I think they're not as noisy. This is what me and her think. And she's at the back of the throat. She can literally see everything's floppy. And remember, it affects everything. So it affects your muscles in between your ribs. It affects your diaphragm. It affects whether this sort of falls back, your joint here. And certainly women with hypermobility, I'm sort of getting the feeling that I think a lot of them don't necessarily have noisy breathing. So I think there's all these extra bits that I just don't, it's just not in the research. And you can imagine if you've got floppy tissues, it won't create such a noise.
Yeah.
It will just collapse and then, you know, so that's one aspect. But I just, we're just different. You know, our ribs are hung onto our spine differently than men. So it's all very different. And obviously, one of the big things is we go through menopause and we're more likely to get menopausal rhinitis, so a congested nose. And if you get a congested nose, you're more likely to mouth breathe. And then if you're mouth breathing, you're then over breathing, and you're not using your diaphragm as much. So your diaphragm can get weaker, and your diaphragm helps keep your airway open when you're asleep. So one of the things, there's an American thoracic workshop report of experts that deliver and prescribe the most common treatment for obstructive sleep apnea called CPAP, and that's where air gets blown into your airway to keep it open. And they said nasal congestion and mouth breathing are common in people with obstructive sleep apnea, and it interferes with treatment because they say the most effective treatment is the CPAP that goes on the nose, but mouth breathing and nasal congestion interfere with that. So my big push is, well, you know, the minimum we need to get people nasal breathing. And the more you nasal breathe, in my experience, and particularly if you improve your tolerance to your waste product, your nose starts to open up. So there's some basic things that we can all try and do. And certainly, you know, I know patients who've struggled to cope with treatment, and a lot of the time it's because they're mouth breathing, they've got nasal congestion. But if they can get that better, they can then tolerate the treatment better. So I think there's so many aspects to it, but certainly if you're heavily snoring, you're stopping breathing during sleep, there's an issue, please reach out to your health professional and discuss about whether you want to have a referral for a sleep study.
Yeah, absolutely. If your partner or somebody tells you you're snoring, thank them. Instead, don't get angry, thank them and go and get it checked, because it is such an insidious sort of thing, isn't it? The other thing about, I mean, you know, before we come back to sort of, you know, correcting the breathing, how much of a role does weight play? Does losing weight make any difference?
Yeah. So unfortunately, the first place we put on weight is our tongue.
I remember you telling me that, and I was thinking, really? Wow.
So, and obviously the tongue forms part of the airway. So, so if you put on weight, you'll put on weight in the tongue, and obviously you can put on weight around the neck. So yes, that is a problem. And obviously if you lose weight, you'll lose weight from those areas. So definitely, you know, clearly as we go through the menopause, it's more difficult with weight. I fully appreciate that. But the data suggests isn't the steep rise in sleep apnea in menopausal women, even when they're corrected for weight. So it's not just about weight. But yes, of course, if you can lose weight, that will definitely help, of course.
Yeah. In terms of then getting to that nasal breathing, things that people can sort of do for themselves. Now you teach this, so what are the basics of basically thinking, well, I can give that a try. And even what I want to study on is whether or not singers do better.
Yeah. So, well, actually, someone asked me, do you think because we don't go to church as much and we don't hum and sing as much, do you think that's increased the risk? And I thought that was a reasonable question. Obviously, I don't know the answer to that question. But essentially, I want to demonstrate what happens, because I don't think people really, truly, I don't know, understand, respect, I don't know the right word. But like, I'm just going to demonstrate it. So...
That's what it's like, yeah?
Yeah. So,
Looks like when
and
Harry met Sally on a really bad day.
but so if you know, I'm seeing people with neck pain, back pain, but they've got this. So this lady who's got a stopping breathing 50 times an hour, neck pain was her main symptom. But she's contracting her neck muscles 50 times an hour to open her airway. And what will
Wow.
be interesting is whether that neck pain improves when she. But when we do that, there's various issues. We are literally contracting muscles and ligaments to open that, so you can get muscle pain. You might have dropped your oxygen level. Your brain needs oxygen, so you could get your brain fog. Your sleep be very poor. All sorts of things happen. Your inflammation will go up at that point. Your sugar, the sugar's pouring into the bloodstream. Adrenaline's pouring in there. So you might wake up palpitations, feeling anxious. All these things, it can be so sneaky. But if we think about it, when we're in the most deep sleep, actually the muscles that only work are the eye muscles and the diaphragm. So we want our diaphragm to be strong. And if we want our diaphragm to be strong, actually it's really important to have good posture. So actually, because if we're like this, we're not using our diaphragm as much. So having a good posture, and we get more diaphragm movement if our lips are sealed and we're breathing in and out of our nose, and if we're breathing slowly and gently. So if we can train ourselves in the day to be more like that, and actually, if we can actually train our bodies to do some of our exercise, if not all of it, with nasal breathing, you really strengthen your diaphragm when you can maintain exercise with nasal breathing. So that's the simplest way to try and help. I appreciate that will not cure all sleep apnea, but I think it's the basic foundation that helps the other treatments work better.
Yeah, and I'd imagine a lot of other people would probably, because you mentioned the CPAP machine before, and this would be something that, even if people think, oh my God, I might have sleep apnea, but I really don't want to be stuck to a machine. There must be things then like doing this that could help say, okay, well, let me try this and see if I can improve it, so I don't have to be on something like that, because that's not the only thing you can do, is it?
Yeah, and going back, sorry, I got distracted, but going back to your, so the muscles around here, all our muscles get weaker, don't they? We want to strength train them, but we're not talking about strength training our diaphragm, the strength training the muscles in between the ribs and strength training these muscles here. That should be part of it. And obviously singing, there was one study on, I don't know if you saw it, on didgeridoo, people that play the didgeridoo, they had a decreased, it helped lower the amount of sleep apnea they're having. So
because it's all that circular breathing.
Yeah, and obviously strengthening. I do some oral pharyngeal exercises every day now to try and help prevent my snoring from coming back. So I strength train here. All my exercise is done nasal breathing, because I know that's going to help me with my diaphragm strength. So there are some simple things that we can do, definitely.
Swimming would be good.
Pardon?
Swimming would have to be good, surely. Although when you're swimming, you're going through your mouth most of the time. You're breathing in through your mouth.
But I always forget this. Swimming is slightly different because you've got the pressure of the water around you. So you're really right that you breathe against the water. So even though your mouth breathing, because that's if you're putting your face in the water, you can only mouth breathe. But because you're breathing against the pressure of the water, you are strength training those muscles. So I do think that's helpful. I do.
Here's a thought, just laterally thinking. If you're starting to develop problems with swallowing, would that also be an indication?
Swallowing, possibly, yeah. I mean, there's a whole... The breathing is so beautifully nuanced and complicated, and so it should be, because without breathing we're not alive. But what should happen is just before we breathe in, our body knows we're about to breathe in, and it sends a signal to the diaphragm and to the pelvic floor to allow both to go down, and the tongue slightly come out of the airway. So that's what should happen. But in one study I saw suggested that in some patients with sleep apnea, they've lost the ability for that tongue to come out of the airway. One of the sort of new fancy treatments is to actually have a device fitted that brings it out of the airway when when you're asleep. It depends on you have to be one of those people that have lost the ability to do that. But swallowing, you know, there's actually a correct way to swallow, and when we swallow properly, we're using all those muscles. But I see a lot of people nowadays, they're not. I'm not a myofunctional therapist, but I look at the way that people swallow, and we don't swallow properly. We're eating too quickly, we chew too quickly, and we're doing a lot of the swallowing comes from the cheek movement, not these movements here.
Interesting, because you don't think about that, really, do you?
No.
Until you choke.
So that's one thing I'm trying to work on, swallowing properly and chewing more slowly. So, but I think we're just so different. We're just living so differently than we used to. So I think all these factors impact it.
Yeah. It's a unbelievably interesting area, actually, one that we massively take for granted. What are your take-home messages then to women if you were actually thinking, what are your take-home messages?
So in the British Menopause Society sleep tool, which I think is brilliant, and it's covering not just sleep disorder breathing, but it's covering all aspects of sleep. It's got a brilliant set of questions in figure 2, and 2 of those questions are, you know, are you snoring? Does your partner say you're stopping breathing during sleep? And if you are, then have a conversation with your health professional about whether you should have a referral for a sleep study. I would also say consider how you breathe when you're asleep. You know, the experts are telling us that mouth breathing and nasal congestion contributes and interferes with treatment. So what can you do to make that nasal congestion and mouth breathing better? Can you return to nasal breathing? The cause of the nasal congestion, it depends, doesn't it? It depends what's causing it. But one cause is that you've got into a habit of mouth breathing, and you need to re-establish that. So those are my take-homes, I think.
Yeah. Just because your breathing technique, basically, in the end, when you're learning how to do this, you're learning how to hold your breath for an awful lot longer. And in some ways, that's decreasing the amount of oxygen that you've got going to the brain. So is that not doing the same thing?
No. So it is different. So when, so the technique that I work on all 3 dimensions of breathing, but the one that you're talking to is what we call Buteco breathing technique. And what that's doing is it's improving your tolerance to your waste product, but your waste product helps us release oxygen to the rest of the body, including the brain. So a lot of people that I see with obstructive sleep apnea, sometimes they're intolerant to their waste products. They've become more sensitive to it, and they feel that air hunger. So they feel that element of I need to take a bigger breath. I'm not getting enough oxygen. I'm feeling suffocated. But actually, they've become intolerant to their waste product. And if you can improve your tolerance to your waste product, actually you get better oxygen delivery to your brain. So so that is something to consider if you think you're someone that suffers with a lot of what we call air hunger. So maybe you feel that you're not getting enough air in, you can hear yourself breathing at rest. Sometimes that's relevant to it.
Yeah. And given you're a woman with the 50 episodes of waking up, and I mean, that's just unbelievable. It's nearly every minute. She must have been absolutely knackered, for want of a better word, every day and not knowing why. But does that mean then that snoring really isn't the only indication? And women who are waking up like that, who've already, who've already treated their bladders, who've already got their HRT, who've already got their anxiety and all of these other sorts of things under control, should they then be going back to their GP and saying, look, listen, I know I'm not snoring loudly because my husband isn't saying to me, for God's sake, or rolling me over 15 times an hour or shoving a tennis ball up my pajamas. So I don't know how anybody could sleep with a tennis ball up their pajamas. Does that mean they should actually sort of go in there and say, look, hang on a second, I really do think that we should investigate disordered breathing in sleep, because I may not have all of these other things, but there's something really wrong because I am waking up with a dry mouth, with a headache, unable to concentrate, tired all day, feel like I'm running on zero.
So what I would say is if somebody puts in NICE, obstructive sleep apnea guidelines, go on the assess bit, And then there's essentially what NICE tells us, say, assess for obstructive sleep apnea if you have 2 or more of these symptoms. And I've got the list here because I thought you'd ask me this. So because I think this is what I use, and I think this is really good. So 2 or more of these. So we've got snoring there, we've got stopping breathing, but we've got unrefreshing sleep, waking headaches, excessive tiredness that obviously is unexplained, getting up from sleep to pass urine, choking during sleep, sleep fragmentation or insomnia, and then cognitive impairment or like brain fog. So if you've got 2 or more of that, NICE are telling us to investigate that. And essentially with that lady, she said no to snoring and stopping breathing, but she had unrefreshing sleep. She was excessively tired. She had sleep fragmentation, and I think she had brain fog from what I remember. And she was postmenopausal. Persistent pain is an increased risk factor. There's other factors that are in my brain. She wasn't overweight.
Oh, interesting. And I had a question there, but it's gone out of my head because I probably have this as well. Oh, I don't remember what it was now. Does it have to be every night that you, or every day that you wake up feeling this way? Or like insomnia, can it just be a number of times a week that you would wake up thinking, God, that was hard?
I mean, it's difficult. I think you have to take like, because it's so, you know, obstructive sleep apnea is one cause for these symptoms, isn't it? You know, they could be multifactorial. So I think you've got to think of it globally, haven't you? Obviously, your doctor probably has done blood tests and looked at other aspects that could be causing it. For me, what I think why I've got such a high pickup rate is I use the NICE guidelines, which I think are good, really good. But I've got a blog on this on my website called Could My Symptoms Be Due to Inefficient Breathing? And I did a blog. It was with Fiona, who's a respiratory physio, and Joe, who's the dentist who fits these devices to help. And we've got 4 tables. So we put together all the risk factors for what we call breathing pattern disorder or sleep disorder breathing. We've got 4 tables. One's for the medication that you're on, one's for past medical history, one's for symptoms, and one's for examination findings. And I've just got it in my head. I just know it. So I knew that woman, I would have ticked lots of boxes on there. So I'm already thinking, right, I think she had 4 of the symptoms NICE, but then I'm thinking postmenopause, persistent pain, there was a couple of other ones, and I'm just thinking that's too many. That's too many for me. I've got to exclude it.
Is it generalized pain, or is it, you know, like my knees hurt?
So generalized. So basically, you know, when we've got what we used to call it chronic pain, we're probably meant to call it now persistent pain. So it's where you've got pain that's either medically unexplained, or the amount of pain you're having seems out of context to the underlying medical problem. Okay. And I've read some data on this. I'm not a pain expert, but what they're saying is that obstructive sleep apnea is more common in those with persistent pain. And that's before then we give them drugs that stop them breathing during sleep. So unfortunately, we sometimes for pain give drugs that nowadays are out of favor, but the drugs, so opiates, so morphine-based drugs, gabapentinoids, so that's your gabapentin, your pregabalin, and benzodiazepines, that's like your diazepam, your temazepam. All those drugs sometimes used to get used for persistent pain, hopefully not nowadays, but they are respiratory depressants. They remove the drive to breathe. So if you're taking someone that's got undiagnosed, untreated obstructive sleep apnea, and it's a chicken and egg, what comes first? Is it the obstructive sleep apnea that's come, then they can't repair their body, now they've got persistent pain? Who knows? But then we give them a drug that stops them breathing. That's a real problem.
Yeah, it really is. And I remember having huge arguments when Dad was in hospital and he'd broken his hip, and then he got pneumonia, as they do, and they still kept on giving him morphine. And I was thinking, can you not find another painkiller to give him? Because you're just delaying the time he's going to go into surgery because he can't breathe well enough to go into surgery. Oh, God, you had these round sort of circular arguments where... when nobody in the hospital liked me. I think they were very, very happy when Dad was discharged, probably even happier when both my parents died. Anyway, there you go. What can you do? Yes, well, so you have to be an advocate for people when you're there, and it does mean that you're often at loggerheads. And to me, that was just a no-brainer. Why on earth would you keep giving a respiratory depressant to a man with pneumonia who needs a hip operation? It just made no sense. So anyway,
and we ran a chronic pain program at our surgery. I'm about to present. I've got an academic poster at the British Society of Lifestyle Medicine. The end of this week was showing, and it was self-reported. And I'm doing the figures from my head, but I think we had. I asked about mouth breathing, snoring. So I think it was 72% of them were declared snoring or apnea, so stopping breathing during sleep. There was, I can't remember now, I think it was like 10% said they were mouth breathing, and there was only a tiny percentage who didn't say that. They said no to both of those. And so this is a massive problem that they're never going to repair their body and be as well rested, and their pain, if we don't sleep well, we all know pain's worse. And we're not looking at that. And what we did on that program was I did a breathing re-education program, and the yoga instructor did a yoga for health program, did it sort of around the same time. And then we had managed to reduce some of these drugs that they're on, because they were on gabapentinoids or opiates, and then some of them managed to completely come off, some reduced the dose, some managed to just stop one. But that's amazing. You can't expect people to come off these drugs if you've got undiagnosed, untreated sleep disorder breathing. Let's get the breathing right, and then if you feel better, then marvelous. So I think that aspect we need to. I think it's completely untapped, that area. I think it's quite big.
You also mentioned there are respiratory physiotherapists. Now, this is not something that I've come across before in this kind of thing. I mean, I would have thought that they were for people who've been in car crashes or something and had crushed ribs and whatever, but they can actually help with this kind of stuff as well, can they?
So this is where medicine gets pushed into different specialities. So sleep medicine's thinking about how we breathe when we're asleep, and respiratory medicine's thinking about how we breathe when we're awake. Does that make any sense?
No. No, because I would have thought we slept 24 hours a day.
So we breathe 24 hours a day. To split it doesn't make any sense.
No.
And if you're breathing, if you're mouth breathing, over breathing when you're awake, what are you doing when you're asleep? Correct it when you're asleep. That breathing pattern is going to continue. So generally, respiratory physios are more to do with sort of asthma, COPD, cystic fibrosis, that sort of to do with respiratory conditions. Probably there's less focus generally on respiratory physios helping sleep disorder breathing. But to me, it makes absolutely no sense. I think the two specialities should be, or certainly breathing pattern disorder and sleep disorder breathing need to come together, and that needs to be one speciality. And I would love every respiratory physio to understand how to help the breathing pattern when we're asleep. Some do, but not all in my experience. And I think from a sleep disorder breathing point of view, I think if somebody's over breathing, so that's that biochemical dimension of breathing, it really impacts sleep disorder breathing. My snoring, I did lots of things to correct it, but my snoring didn't properly stop until I addressed my overbreathing. I was breathing in excess of what I needed. I corrected that by practicing exercises where I underbreathe, and then my snoring stopped. But that won't be for everybody. That won't be for everybody. But and I personally think as women go through the menopause, and I've got reasons biologically why I think this happens, I think there's a tendency for women to start to overbreathe. Yeah. And the trouble is, the traditional treatments we've got in medicine at the moment don't tackle that. But that's my personal opinion.
When you say overbreathing, I mean, we normally breathe, I can't remember, what is it now, 60 or so times an hour, a minute or whatever. How many times? I don't even remember. No, it's 12. Is it 12?
Oh, God. I think they've increased it because everyone's breathing too fast. So if you look in an old textbook, it'd be different than what it is now.
Yeah, it used to be 12, I think.
That won't be in a textbook now. So we only need about 6 litres, generally, it depends on your size, but generally we only need probably about 6 litres of air per minute. There was one study I looked at, so the asthmatic, the patients with asthma, and they were breathing 14 litres of air per minute.
All right. So it's not necessarily the number of times that you breathe in, but it's the volume of air you're taking in. So they're really trying to take in a lot more than they would sort of necessarily need. Because I would have thought, okay, if you're really filling that diaphragm and you're taking in lots of oxygen, that would have been a good thing.
No, because if you're breathing bigger, you often have to breathe faster. If you breathe faster, then it's a bit complicated, but the amount of air that you lose in the bit that you can't breathe, what we call dead space, becomes proportionally more of a problem. So we want to breathe slower. But if you're breathing 14 litres of air per minute, you're not going to be able to breathe at 12 litres, because you'd have to breathe if you were breathing at 12 breaths per minute and you were breathing 14 litres of air per minute, you'd have to breathe over a litre every breath. It'd be massive. And when you overbreathe, you're less likely to use your diaphragm, which is that main breathing muscle. You tend to breathe more into your higher chest.
So you're doing a lot more sort of panting, sort of, rather than you are.
So it's more upper chest, and you've got less air sacs higher up here than you have down. So we don't want to overbreathe. And if you think about it, if you've got a collapsible tube here, so imagine, say I had a thick milkshake and you had a paper straw that was collapsible, and you want to suck it, you know that you've got to suck it slow, because if you go, it collapses, doesn't it? So that's the same here. If you overbreathe, and in my experience, my clinical experience of working as a breathing practitioner, when people are overbreathing, their nose gets blocked. And they switch to mouth breathing, which makes their nose congestion worse. So you then are throwing nasal congestion in with overbreathing. It makes it more collapsible. So that's my experience of it. So yeah, we don't want to breathe in excess. And the reason why, if you think about it with exercise, if you're at rest and I'm breathing efficiently here, I'm going to breathe heavier and faster as I exercise. That's normal. I'm going up like this, and then at some point I'll reach my maximum breathing capacity, and then I can't do it. I want to stop, or I'll gas out. But if I'm already here and I'm already over breathing, I can only do that amount of exercise.
Yeah, that does make sense.
Yeah. So we don't want to be excessively breathing. We want to have it as efficient as we want to at the bottom. But it's so complex. I think it's so complex. And actually curing or managing, I suppose is the right term, of managing obstructive sleep apnea, it's personal to the person, and it could actually involve lots of different disciplines, sleep medicine, even respiratory medicine, respiratory physios, breathing practitioners, myofunctional therapists, functional dentists, sort of airway dentists, even osteopaths. There's a whole what's causing it. We just assume, or we just need to blow air into the airway. It's more complicated than that. So,
and if there are things that you can do for yourself, I mean, then God, you'd be crazy not to, really, especially if they're quite simple. Yeah. So, I mean, if people want to find you to find out how to improve their breathing, then where do they find you?
So if you just put Louise Oliver breath doc into Google, hopefully it should bring up my website, and then there's various different options on there. So, and there's lots of podcasts, and I've got loads of stuff, blogs and stuff that's got information on there. So as well.
Yeah, did you, of course. I loved it, actually. It was so interesting. It was fun. Clearly, I need to go back and refresh myself, and I think I will actually go and see if I can get a referral to a sleep clinic. Do you have to go to a sleep clinic, or can this be diagnosed at home now?
So you can go privately. So you can go through like a private sleep clinic. You don't have to use the NHS, but it generally involves a sleep study that generally you do at home. Obviously, the gold standard one is a fancy in-hospital one.
People sort of imagine you're going to go in, you're going to have a head wired up for the entire night and God only knows what else. But it doesn't have to be that complicated.
No, it doesn't. No, you can have one done at home. Now, whether there's a whole piece of research that needs to go on, and I think really specific research about actually looking at women in hospital and working out how we breathe. So I think the whole diagnostic criteria of how we diagnose it needs to be completely looked at again, and start right back from the basics, and actually get a new diagnostic criteria specifically for women, and then somehow get that new criteria into a home sleep study That's what needs to happen, in my opinion. And then when you know why women breathe differently and how they breathe differently, then you can look at treatment, then you can look at prevention.
Yeah, yeah. Just briefly, I mean, when you say women breathe differently, what do you actually mean?
So they breathe differently. Let me just turn that light on. They breathe differently. So we are more like, our ribs are put on our spine differently. So on a man, the ribs are put horizontally like that onto the spine. With a woman, they're more like this. So they're like diagonal. And that's presumably so that when we're pregnant, they can move up out of the way. So we are primed that we are more likely to become upper chest breathers. It doesn't take as much for us to come upper chest. Our airways are different size. Our diaphragm's smaller. There's all sorts of different anatomical, and obviously it will vary between different people, but we are not just small men.
Yeah.
So, and what happens with women, so in a sleep study, they class it as when you block your airway and you do it for 10 seconds or more, that classes as an apnea. Okay, so you'll get, on that woman that had it for 50 times, that'll class as a 1. It'll score a 1 then. But if you block your airway for 9 seconds, it won't score.
Still got to be doing some damage.
Exactly. And then the other one is, it's a bit complicated, so I won't, but if you narrow your airway enough that you generate that fight-flight response to wake up, it sort of depends on how long you've done it and how much you drop your oxygen, so I won't go into that. But again, you have to hit the criteria to get the point for it.
Okay.
But we know that women, they don't stop breathing as long as men, and they don't quite drop their oxygen as enough as men. So quite often they won't score. So I have some women who I know they don't breathe when they're asleep, but they have a normal sleep study, but it's just because they've not held their breath asleep. They've not stopped breathing just for quite long enough for it to mark it. So, and actually,
you need a whole different diagnostic criteria.
And what the data says is actually it probably is worse for us to be multiple like punctuations in our breathing rather than one long one. Just, you know, if you had one long one that was intermittent, yes, it destroys your sleep at that moment. But if it's only happening every so often, that's probably not as bad as multiple times in an hour. So we need a completely new diagnostic criteria.
Yeah. Yeah, actually right. We are not small men. Yes, I wouldn't mind going in. And this has been my last couple of weeks. I've tried to put dishwashing detergent onto my salad. I've almost tipped my spit your tea. I've almost put my dinner into the bin instead of the scrapings off the chopping board. I have not turned up for a meeting that I actually asked for, which is always good. I'm literally just not remembering anything at the moment, just not remembering anything at all. So I think it's time I went along and maybe had my sleep assessed, perhaps, because clearly there's something wrong when I'm with my memory when I'm waking up during the day. Cannot remember anything.
It's definitely, I think it almost is, you know, there might be some sleep consultants who disagree with me, but I almost think, you know, you can do all the standard stuff first, but if you're really struggling with someone, you don't know what's going on, to be honest, I'm just thinking, well, I'll just do a sleep study. It's almost like an exclusion. Let's exclude it because it can be so hidden. And unfortunately, I'm getting a few surprises.
Yeah,
so,
it looks like you are. Yeah.
Yeah.
The other thing I did was I had a cold last week and I blew my nose. So I had my toilet paper. Yes, I am that attractive. Blew my nose on my toilet paper, came in with a handful of washing into the bathroom, went to throw the washing into the toilet instead of the toilet paper. So there you go. That's where I'm at.
I think get a sleep study, Fiona, I think.
Brilliant. But you're lucky I remembered to come here tonight. Brilliant. Anyway, my love, I will let you go and let us push for getting changes to the diagnostic criteria, if I remember.
Thank you for including it in the book, Fiona, as well.
Yes, I'm very impressed with it, actually. I think I'm before my time on that one. So
get the book
and find out more about your sleep and why sleep apnea matters. Yes. Get your vasomotor symptoms treated, get your blood pressure treated, get your sleep checked. That's my message. All right, my love, I will let you go. And thank you again. And we will speak again soon, I hope. Sooner than the gap we've had, but it's been a couple of years.
No, time goes too fast.
It does, doesn't it? Anyway, I will speak to you soon. Take care.
Okay.